Hello, everybody, and welcome to our next episode of The Future of, where we are going to be talking today about precision medicine and how AI is accelerating on the delivery of the long-time promise of personalized healthcare. So, I am very excited to introduce our guest today, Gareth Sessel. He is the Chief Growth and Product Officer at InnovaHealth.ai. He is also a medical doctor trained at Oxford and engineer as well, electrical engineer, right?
Correct. Thank you so much.
Yes, thank you. Yes, Gareth, tell us a little bit about yourself.
Yeah, thank you so much for having me, AJ. It's great to be on. As you said, that was a very kind intro. I started my career as an electrical engineer, specialized in artificial intelligence when I was still training. So that was way back when, before it was, I guess, as popular as it is now. And then I absolutely fell in love with healthcare and decided to go all in and become a medical doctor, as you said, at the University of Oxford. I came to the US, did a lot of modeling work with Johns Hopkins University as a visiting scholar there, and then transferred to UCSF. So I really wanted to explore the Bay Area and fell in love with the space here. So I'm currently living in San Francisco. I've done a lot of consulting work and head of product and head of business development work for a multinational publicly traded health payer. A lot of that work has involved digital biomarkers, validating and developing them. And now I run a boutique consulting firm dealing with product, so development and validation, as well as business development and partnerships. And again, largely focused around digital biomarkers as well as other medical devices.
That's amazing. And digital biomarkers is something that I am getting more and more interested in as that's coming to fruition. This idea of, really being able to zoom into all of the different aspects of an individual, as well as, aspects of a population that maybe we haven't thought about before. So before we get started into what the future looks like, why don't we talk a little bit about what today looks like, or what yesterday looks like in the status quo, and then we can get into where we're going with that.
Yeah, absolutely. I think that's a great place to start. And, it is very much still today, both in the US and internationally. So today, most medical care is delivered in what's called a one-size-fits-all approach. Obviously, there are exceptions, there are precision oncology centers and things like that. But in general, if you present with a chronic illness, if it's COPD, if it's diabetes, if it's depression, all of these kind of conditions, there's a first-line treatment, a second-line treatment, a third-line treatment. So what happens is the healthcare profession looks or conducts large population-based studies. And from those large population studies, they extract trends. They look at the data and extract trends. And then these international societies will develop guidelines based on those trends. And when you present to your doctor will treat you according to these guidelines or these protocols. So they are evidence-based. Nobody's saying that they're not, but and they are somewhat precise, but essentially they're still designed around a population average rather than the actual individual sitting in front of you. And that's where, personalized medicine comes in. So I always like to explain it using an analogy of, let's say you're driving around in your car and your check engine light comes on. So you take your car to your mechanic, and your mechanic plugs in his diagnostic computer and runs some diagnostics and says that the engine light is on because your engine is overheating. Now, because of your specific car, the most common cause of engine overheating is water pump failure. So your mechanic replaces the water pump, resets the engine light, and sends you home. And in most cases, that fixes the problem because that is an evidence-based approach. Your mechanic is saying, I know your car, and I know that in many cases, the cause of engine overheating is the water pump. But in some cases, let's say for you, on your way home, your check engine light comes back on. So you take it back to the mechanic, and he says, all right, the second most common cause is thermostat failure. And does the same thing, changes the thermostat, resets the check engine light, and sends you home. again, in most cases, now you've done the first line and second line intervention. So in most cases, that fixes the problem. But in some cases, you go back and they change the radiator and then the cooling fan and so on and so forth. Now, why I like this example, and it's potentially doing some disservice to mechanics because they're actually far more precise than this. But healthcare providers aren't necessarily more precise than this. But you can't say that this isn't an evidence-based approach. This is a clear protocol-driven, evidence-based approach to fixing the problem. But you can also see how inefficient it is, and more importantly, how dangerous it is, because you could be driving around, continuously driving with an engine that's overheating, and that could cause catastrophic engine failure. If that engine is a part of the body, that is a very real problem, and we need to be more precise. We need to be better, and this is where digital biomarkers, in fact, all biomarkers and precision medicine, really lets us zoom in and do a lot better and be a lot more precise.
Yeah, so it's a lot of trial and error, and I've experienced this, especially, and I think a lot of people, I've written about this before, but my journey and struggles with long COVID, right? And, this is something that's still impacting a lot of people, and it was and continues to be hit or miss. I'm going in, asking questions. A lot of times I don't know what questions to ask, and I just get, very pragmatic. Okay, let's look at this. Let's look at this. Let's try this. How about this intervention? How do you feel? It's very qualitative data. I mean, now, I'm in a clinical study that I have 2 fitness trackers on. Yeah, that we're trying to figure out between this and blood draws and surveys on how I'm feeling, trying to find any information that would indicate, oh, I'm about to have a crash or I'm in the middle of a crash. And if we could find that, we could start treating it. But up until this day, I mean, this has been 4 years. I don't have any treatment, right? Yeah. It's still get rest, go try to exercise. That's it.
Yeah, absolutely. So the very fact is we're developing so much data, naturally just putting out data into the environment, whether it's through wearables. People have smart sensors on their mattress. People have you walk around with a smartwatch. People have remote patient monitoring devices, IoT devices. Your smart scale might be connected to the internet. The amount of opportunity to collect data that we all just engage with as you're scrolling through social media, as you're shopping on Amazon, all of these kind of interactions actually says a lot about you. We're throwing data out into the environment. The data collection opportunities outside of a clinic hugely exceed the data collection opportunities inside a clinical environment. So you see a doctor, they maybe spend 15 minutes talking to you and entering some notes into a computer based on a very structured questioning framework or an interview process. That is a very limited and finite and episodic collection of data. And if you look at the ability to make predictions based on that data versus the ability to make predictions based on all of the data that's collected outside of a clinical environment, you really start to see the power of using that data more strategically.
Yeah, so let's take a step back because, in the past, it was a lot of biological biomarkers, right? And now we're talking about digital biomarkers. So
sure.
Let's talk a little bit about deep diving into what a digital biomarker is and then why this data, the diversity of data, now becomes relevant.
Yeah, absolutely. So, I mean, that's a great point. So biomarkers as a whole are really just any indicator of a biological state, right? And biomarkers themselves will play a very key role in the delivery of precision medicine. But there are multiple types of biomarkers, and there are also multiple types of measurements, and sometimes something can be both measurement and biomarker or just one or the other. So let's say you've got physiological biomarkers and physiological measurements. These are things you're probably very familiar with, your blood pressure measurements, heart rate measurements. These are both measurements and biomarkers because you understand that a blood pressure of 200, a systolic blood pressure of 200 millimeters mercury is you understand that that's too high, so that is an indicator of biological state, but it's also a direct measurement. So that's a physiological biomarker, and you've got standard vital signs. Then you've got things like biochemical biomarkers. So you go to your doctor, they draw some blood, the blood gets sent off to a lab, and they measure the hemoglobin levels in your blood, or they measure the number of neutrophils in your blood. These kind of biochemical biomarkers, and those biochemical biomarkers can extend to genetic biomarkers, because you take a cheek swab, send in for genetic testing. You do some next generation sequencing, whatever it might be. That's a biochemical biomarker, and there are different subtypes of those. And then you get things like imaging biomarkers. So you take your chest X-rays, and what does that say about your biological state? But then you get the evolution of these digital biomarkers, and digital biomarkers are calculated scores, and those scores, those outputs from those scores, provide insights into your health. So what goes into them is lots of different measurements, and measurements can include things like accelerometer readings from your smart wearables. It can include traditional other biomarkers and other measurements. So things from your electronic health record can go into that algorithm that's predicting the score. It can be things that are, so I would divide it into traditional clinical inputs or traditional clinical metrics, and those are things like blood pressure and heart rate and BMI, and things that are less traditional, things like your accelerometer data from your watch, or your smart scale measurements, or your shopping behavior, or your credit score. All of these kind of things might be useful proxies for health conditions, and if they are fed into a sophisticated model, that model then produces the score, and that score says something about your health.
So really interesting. Over the past decade, the work that I've been doing, we've talked a lot about collecting all sorts of diverse data and trying to put it into some healthcare platform. And I think a lot of it, there was an intent to use it towards precision medicine. And I think there was some success, but there was a lot of under-delivered promises on that. So now we're in the era of huge data sets. Why is it different now?
Yeah, I mean, so if you look at the amount of information, the amount of data that's collected through traditional precision medicine, I should take a step back. So let's talk about how precision medicine began and why it has been so exciting for so long. And it has achieved many great outcomes, but I think the excitement has waned a little bit since it was first promised. So way back when in 1990, we started this human genome project, and it took 13 years and cost at the time was like $3 billion to sequence a full reference sample of a human genome. And there was the belief that if we understood this, there's this central dogma of biology is like DNA is transcribed to RNA and RNA is translated to proteins, and diseases occur when something along that process goes wrong, or there's some variant, some unexpected or problematic variant that occurs along that process. And if we understood all of the genetics involved, then we would be able to be much more focused and apply treatments specifically to those variants. And the problem really has been for a long time that the cost for sequencing a genome has been so high, the effort has been so high, the time has been so long, and the amount of data that you collect has just been overwhelming. So more than most facilities can deal with. As times progress, so you get now we get next generation sequencing, that came out in early 2000s, and that has made huge strides. And now there are many different groups trying to race towards the $100, full whole genome sequencing accomplishment. Oxford Nanopore and NVIDIA recently, well, not already a couple of years ago, managed to turn around a whole genome sequencing study in 7 hours, and actually helped deliver treatment to a very sick infant who was having uncontrolled seizures, and they were able to identify the underlying cause using this genetic assessment in record-breaking time. But the point is, it's really not standard practice, and there's a drastic shortage of data available to draw conclusions from these genomes. And that brings a lot of challenges with it. So linking, it's still not standard practice, it's still not reimbursed. And even though these things will become more affordable, it's still very, very difficult to scale. And beyond that, this is now a type of biochemical biomarker, a genetic biomarker. It still needs to be collected in clinical settings, and that raises accessibility problems. It's time consuming, it's episodic, so you only get information at that point, not continuous or ongoing. Digital biomarkers are non-invasive. They can be passively measured. They can be measured continuously and in real time. It's much more affordable. It's much more scalable. They reach the developing world and rural populations, and they occur beyond just the clinical wall. So they actually are real-world data collection, and that makes them much more flexible, much easier to scale, much more practical to actually roll out. And this is why. So your question was, why now? Why are we making so much progress now? I think it's a combination of, now we have the compute and the storage capabilities and the data sharing capabilities and the model training capabilities that we didn't have before. So genetic testing, genetic biomarkers are becoming much more relevant. But at the same time, all of that compute, all of that data collection, all of the sophisticated devices that we're walking around with, whether that's smartwatches or smartphones or IoT scales, or all of these kind of things, is just throwing more and more data out into the environment, and from that we can use sophisticated models to create these digital biomarkers that really makes tailor-making somebody's healthcare journey much easier and much more effective.
Do we find that building these sophisticated models on now a lot of different data points and a lot of different types of data points begins to relieve some of the pressure that we face, where if you have patients going through things like a clinical trial and they're not adhering to the protocol 100%, can we start supplementing that with, okay, here's the information we do have, and now we can start to relate and fill in the gaps that maybe we're not getting the information from the patient, maybe they're not filling out their journal, coming in for the episodic measurements, but we have enough to make decisions.
Yeah, absolutely. So the models can be structured in such a way that they can calculate scores and can be flexible enough so that these scores can be calculated even if there's missing variables in the input. The power and the strength of the output is obviously higher the more relevant data goes in and the cleaner the data that goes in, but they can be dynamic enough so that you don't necessarily need all of the inputs to calculate a score. Beyond that, there are so many different methods of making participation in things like trials much more convenient, much more accessible to the patient, so that drop-off rates decrease. So if you are, for example, just passively monitoring heart rate and heart rate variability using your smartwatch, there is no additional effort for the patient. So you're just collecting that data in the background. They don't need to present to a clinic. I know another one of your friends, Luke, is doing similar things with eye tracking. So the idea here is this is something that patients don't need to actively engage with. And the other benefit is it's no longer subjective. These are objective measurements. So it's not self-reported, but you're actually getting real quantitative results in real time. And these are continuously measured. So as opposed to episodically measured, which can be problematic for multiple reasons. One, you actually need to get participants into clinics, which makes it more expensive. It makes it less convenient. But the other thing is you sometimes get noise. So you get things like white coat syndrome. So say you're measuring blood pressure as one of your inputs, and white coat syndrome is a very common thing. You present to your doctor and your blood pressure is high because you're nervous in that environment.
I have the same thing. Yeah.
So if you can put it out of your mind as a trial participant, and it's just happening in the background, you get much more real world relevant results, and that can be incredibly helpful.
I would imagine that there would still be a lot of noise based on the information coming in, because these are not, or a lot of the devices that people are going to have in their homes aren't really FDA certified. They're not giving high quality data. They're giving general trend data, I would say.
Absolutely.
So how are we filtering that noise out?
So there are a variety of techniques. I mean, the first is just to say that most of these sensors are getting better and better and are actually becoming more uniform. But there's no doubt that there's also no shortage of poor quality devices, poor quality sensors, and certainly ones that aren't validated by FDA and other. So if you were conducting a clinical trial, you might focus on using higher quality devices that have some validation behind them. But also, you don't necessarily, it depends what you're trying to do. So if you're trying to publish and clear FDA regulations, the requirements are a little different. But if you're just trying to measure trends, deviations from baseline are incredibly powerful because you're less concerned about absolute values, but more about behavior changes. So let's say you're talking about, trying to predict depression in somebody. Causes. So some of let's look at some of the diagnostic criteria for depression in either DSM-5 or the ICD guidelines. Things like insomnia and hypersomnia are there, which means your sleeping behavior, is an input into the criteria for whether or not a person has depression. And really, what's valuable there is how it's changed from baseline. If there's diminished interest or pleasure in things that you would otherwise find interesting or pleasurable, that is a criteria in the diagnostics. But how do you define that? What you actually need to understand is a deviation from baseline. So you need that baseline. Similarly with ability to concentrate. So how well do you normally focus? And then if that suddenly changes, that is indicative. It's not just saying, you always need a baseline reference, and then if that's stable, regardless on how you're measuring, if you've got some stable value and you see a sudden change, that is indicative of something, and that delta can be extremely powerful.
Yeah, I remember we were talking about this, idea of getting the baseline and then deviations being an indicator of something happening. And I shared a story about my grandfather who always went to the same diner, I think 2 or 3 times a day. And he was getting a lot older. And one day we got a call from the diner, the owners there, and said, "Hey, we haven't seen George in a week." We would have had no idea that something was changing. And it turns out that he fell and then was struggling to continue his normal everyday activity. We wouldn't have known.
Yeah.
Right. But one of the things you mentioned is incorporating things like financial and transactional data. Right. And I loved the chart that you showed me before that said, hey, we could start bringing in information around how you're interacting with the internet, right? What sites, how often you're on, what your activities are, or how you are, being social in the world based on different things. And from all of this, we could at least infer that there's something that has changed. And then we could dive deeper into that.
Yeah, absolutely. So I think there are also different degrees of how predictive some of these values are, in terms of sensitivity and specificity. So if I may, I'd like to just outline how you can use these things as proxies for
Absolutely, yeah.
other health conditions. And I'm not for a second suggesting that the way you shop on Amazon is directly correlated with a specific disease, but it is a useful input because let's say you have a strong interest. Let's say you have a strong interest in a new hobby, and all of a sudden that changes. It may reflect in the way that you shop online, or you suddenly develop a disease that causes your appetite to decrease. If you typically buy your food online, it's going to change the way you shop for groceries and the frequency with which you shop for groceries. So these are just proxies, and I like to also just describe something that I found quite interesting with a recent client. So I was helping the clients clean up data for occupational health reasons. They run this particular client is in charge of ensuring of protecting occupational health in workers in a large industrial factory. And it turns out that one of the things that they need to protect is hearing. But it's a big struggle to get some of these employees to wear hearing protection. And that's because the employees rely on being able to hear when machines are going to start malfunctioning. So based on, the machines all have a characteristic sound. And when that sound changes slightly, they know that something's about to go wrong long before the sensors in the machines start to flag problems. So the sound here is just a proxy. The audio profile is just a proxy for something that's going wrong, but it's easy to measure, and that's kind of what shopping behavior or credit score or something like that might be. It's not necessarily very sensitive. It's not very necessarily very specific, but it probably is very sensitive. And if you do a lot of analytics, or if you just have this as one input into the system, it can really increase the predictive power that you're working with. So, if you're trying to detect depression, or if you're trying to see severity of depression, or if you're trying to come up with a lot of these predictive tools, these non-traditional, so traditionally non-clinical metrics can actually be very, very useful because it shows the knock-on effects from things that are going wrong, and from those knock-on effects, the knock-on effects often appear before symptoms appear, and patients typically only present at clinics when a symptom appears, and at that stage it's quite late. So the idea here is digital biomarkers would actually empower us to catch things much earlier on in the disease process, because the subtle changes that people typically ignore or brush off, they would quantitatively capture, and that would allow us to then intervene much sooner.
So you mentioned sensitivity, and we're talking about, I would say, some pretty sensitive personal information. You mentioned credit scores, transactional data. So let's talk a little bit about the privacy concerns, how that's affecting people's willingness to share that data, and then how that's preventing organizations from actually maximizing the use of that data.
Yeah, so I think there's a lot here, and we could probably speak for several hours just on this topic, right? So maybe there's two main components, though. There's the idea that this is confidential information and nobody wants to necessarily share that, just out into the open. And then there's the second issue, that a lot of healthcare data is typically collected by individual health systems, or individual payers, or individual doctors' offices, and then it becomes very siloed. So, maybe I'll address the second one first. Is this idea of data siloing? So to create either digital or biochem or genetic biomarkers, we need a lot of data.
Mm-hmm.
And for any model training, you need a lot of data. To validate, you need a lot of data. So this is a real problem. This is a real bottleneck in rolling these models and really rolling these models out and really delivering precision healthcare. There are multiple ways of overcoming this. We're making progress in de-identifying data and sharing that. We're making progress in using synthetic data, and that can be very powerful. And then there's another method called federated learning. And federated learning allows you to train models without, you have greater access to different data sources, but you don't require access to the raw data itself.
Mm-hmm.
So if I can explain that a little deeper, normally or traditionally, when you train these models, you collect all of the data that you're going to use in one central location, and then you use that central repository to train the data. And federated learning says we understand that data is siloed and that it's very protected, and nobody wants to share that data, both the patients themselves as well as the institutes and organizations that collect and protect that data. So what I'm going to do is I'm going to take the model to those different data sources, train it locally on those servers, or basically on those servers. And then when I take the model back, I've never had access to the data itself. I'm just taking the trained model. And that way the data remains protected and safe. And, it's very difficult, if not impossible, for me to reconstruct the data. And that way you can still train data on very diverse sources, very diverse patient groups. And it really overcomes a lot of limitations from this data siloing problem.
Yeah, and I think we're seeing some more of that. I've definitely, in my exploring the digital biomarker space, I've seen efforts in the open source community to try to get development to be democratized across a lot of different researchers. And then I've seen research and institutes begin to open up some of their data sets and offer that to researchers and independent innovators to, basically create a community and create an ecosystem where a lot of people are able to participate in what you said, federated learning, that can leverage the data. Because having it siloed, I can understand there's value in that data. So you're protecting some of your
Exactly.
IP, you're protecting, a differentiator. But at the same time, it's like you said, it's stifling the advancement of digital biomarkers, precision medicine, understanding diseases at a deeper level. I've even seen some of this where, you have the siloing between organizations, between companies, but then even within the company, there are different teams that are protecting their own data for a variety of reasons, and they're not sharing with each other.
Yeah, absolutely. So, very real problem. And like you said, I completely understand it. It's almost a sense of responsibility as well. You're responsible for protecting this very confidential information. No patient wants to think that their data is just being handed out freely. And that comes with a lot of responsibility. So I fully understand and appreciate that, and certainly wouldn't advocate for anything else. And I do think the federated learning approach is a very exciting opportunity to maintain that confidentiality and still make very great progress with training these very impactful models. And there are open source and very powerful environments available to any researcher who wants to implement these things. So there's one everybody knows. Well, ML Commons is a big group, and they've got MedPerf, which is doing exactly this. It's providing an environment for this kind of federated learning structure. NVIDIA has their Flare environment that's doing the very similar thing. It provides an environment for federated learning. And has been used in healthcare, and it's just a very powerful way of ensuring privacy is respected, but still not hindering progress.
As a patient, let's say as a supplier and creator of this data, I would imagine trust is really important.
Yeah, definitely.
I want to know who's using my data, where that's being stored. I want to know that it is protected. I want to know the brands that are buying and leveraging that data. So, what efforts are being made there? Or is it, this data is being captured and it's being de-identified to some standard and it kind of goes into a black hole as far as myself is concerned?
Yeah, I mean, I think there is a lot of effort by all major governments really to introduce legislation that protects. Often it's difficult in that the tech is one step ahead of the legislation. But there's certainly a lot of efforts from government to ensure that data is not being abused and confidentiality is respected. And it's the truth is, tech is generally obviously there are exceptions, and there are very public exceptions, but everyone I've come across is very aware that this shouldn't be abused. This is very sensitive information, and treats it very respectfully. So yeah, this is a developing field, and we just doing our best to ensure that this is really prioritized. You don't want sensitive information leaked out there.
Going back to branding, another thing that I've seen in the industry here is, you have large companies. You mentioned NVIDIA, but also Google's working on this. Amazon, Walmart, they all have health and wellness. They're all pushing forward in this effort. Would you say that in some instances their own brand could be holding them back in making progress, just because me knowing that, oh, my data is going to go to Google, and there's a connotation around that of mistrust? So how is that impacting companies' ability to collect that data?
I mean, that's a really interesting question. I think it's interesting because there are certain companies that have really prioritized this message of privacy. Apple is the big "we protect your privacy" company, and then there are companies with, and I don't necessarily need to name names here, but there are companies with much poorer reputations for dealing with confidential information or your own data. And I do think that has an impact. People are much less likely to share or agree to certain terms of service with those other companies, especially giving them access to much more confidential information. There's some degree of, even the companies with the worst reputations are still collecting enormous amounts of data just because people love their services. But I guess users would be less likely to provide access to things like their health data or credit scores or those kind of sensitive metrics. So I think that's very real, and I do foresee a lot of these bigger groups putting a lot more effort into making sure their reputation for handling sensitive information is improved.
One of the things that you mentioned is synthetic data, and how that is also helping to drive the development of these new models. We had a whole other episode about synthetic data, but for those who have not watched it, let's talk a little bit about what synthetic data is, how that is different than real world data.
Yeah, I mean, the idea is that synthetic data, synthetic data is data that looks and acts as if it came from a real patient. For example, if it's healthcare data, and would mimic, say, a traditional disease trajectory, but doesn't belong to any particular patient. So it's not confidential or it's not sensitive information because there's nobody on the other side that, that patient doesn't exist. But it's not random data. It's specific to a hypothetical patient, and it's actually created to mimic a hypothetical patient. I know in your last episode you actually discussed much more technically what that involves and how you would go about doing that. But for the purposes of this conversation, I think it's just important to understand that it's data that's useful for training models because it mimics an actual disease process, or it mimics an actual patient's response to medication. So because it mimics real life, it's still valuable. But you overcome a lot of the limitations of privacy concerns because there is no patient there.
That makes sense. So I'd love to shift gears a little bit to something we talked about before, and let's focus back on precision medicine, where that's headed, and the benefits that we're already seeing out of it. So we talked a little bit about type 2 diabetes, and for a long time, it was considered there's type 1 diabetes, there's type 2 diabetes. But now with the data that we're collecting, we're starting to see that a little bit differently.
Yeah. I mean, type 2 diabetes is just one label. The truth is, historically, the way diseases have been classified is we do these large population studies and we identify similar characteristics and we group patients together if they're presenting in a similar way, and then we throw a label at it. And then if it's a very simple disease, if it's caused by, say, one genetic mutation, then it's very easy to say that this genetic mutation causes this disease, and then it becomes a lot more, a lot less vague. But with something like type 2 diabetes, well, it's something like diabetes. There are specific underlying causes of diabetes. So you get, but let's say you take diabetes as a whole, and you take out people with type 1 diabetes and this other group called ladder, and from there you take out people who can be excluded because they have a very known cause for either there's a single gene mutation that's causing them to be either insulin resistant or hyperglycemic. But in many cases, in the vast majority of cases, so something like 85% of people with diabetes, there is no easy to point at one single cause of the disease. So it's just this big umbrella term. And the problem with that is it's like trying to treat your overheating engine just by thinking, okay, this is just one overarching engine problem. I don't want to replace the entire engine. So with modern clustering methods, and there are a lot of studies that are trying to figure out and subclassify different subtypes of type 2 diabetes. And from this big population, it's tens of millions of Americans trying to figure out, instead of coming up with blanket recommendations, every person needs eye screening for diabetic eye disease this often, every person needs monitoring for kidney disease this often. There are groups within that cohort who are far less likely to develop those complications, and there are groups within those cohort who are far more likely to develop those complications. And knowing that, you can tailor make somebody's care journey to say that, all right, this person, I'm going to start screening them for diabetic retinopathy immediately and every 3 months. And for this person, I'm going to really focus on managing their cholesterol and high blood pressure because they're much more at risk of complications that arise from these unmanaged comorbidities if I don't. So the other thing is, like, who's going to be more sensitive to which medications? So, some people have higher fasting blood glucose. Some people have higher insulin sensitivity. Some people have, the actual mechanisms at play for the ultimate disease profile are very different in different groups. And this umbrella term, just type 2 diabetes, isn't distinct enough for us to most effectively manage that patient group.
Yeah. One of the things that we talked about, so going back to some of the challenges that we're seeing, you mentioned the legislative challenges, policy challenges, lagging behind. You mentioned some of the social challenges that we have. And then payer challenges and reimbursement. There's all these different challenges. If we were to take a look at the provider side of the equation, and this is circling back into what we just talked about with, now there's different subtypes that we're identifying and comorbidities with this thing that we call type 2 diabetes or any disease. So now from the provider side, you're being inundated with a lot of different information. The data is there. There's some conclusions that are being drawn by the algorithms, by these models. So how is that affecting their ability to provide care?
Yeah, I mean, it's a great question. I think it also comes back to what you were saying before, is why is now such a powerful time for precision medicine? And it really is just the evolutions that are now for the first time really available to providers and your everyday clinics. So now there's more data than ever and more measurements than ever, but also there are more of these FDA approved supervised ML, typically type of scoring systems and algorithms going in, creating these digital biomarkers. And there's more of these subtypes of diseases, as you said. But the ability to handle large data sets is now more sophisticated than ever. So, especially with the advent of things like LLMs and generative AI, these tools are able to collate and organize unstructured data from clinical notes. And that's also been a problem. You as a treating doctor, you can sometimes get this huge file, and just going through all of the clinical notes in an EHR can be overwhelming. So for the first time, we have these tools, and specifically AI agents, that can really support decision making. So you get very sophisticated clinical decision making tools, clinical decision support tools. You get very efficient summarization tools, and really these tools can flag things that might otherwise go unnoticed. They can spot trends and patterns, and really the AI itself, because of the compute, because of the data sharing, because of the abundance of scores that now exist, really can help you refine treatment. And it's stuff that no individual human brain can necessarily do, in the same way that you don't expect a pilot to deal with all of the sensor data from a modern aircraft in real time. There is an autopilot system there that is doing things that no human pilot can do. Now we have LLMs and Gen AI agents that are doing similar functions for dealing with all of the data from all of the sensors and all of the algorithms in modern healthcare, and that's really very important in precision healthcare going forward.
And you wrote about that in your article. I love the example of the pilot who is being introduced to autopilot and then doesn't trust it and refuse to adopt that technology. And that's equivalent to providers today not trusting the outputs of these models and sticking to what they know. And this is the challenge that I saw working on healthcare platforms back in 2014, and I'm sure it was earlier too, is that the data came in, it was presented in more of a raw fashion that required somebody to sit down and make conclusions and actions on that data. Whereas now what I'm hearing is we're getting more comfortable with the sophistication and accuracy of these models that we can begin to, again, it's coming back to trust, providers can trust some of the recommendations that are coming out of these new systems.
Yeah, without a doubt. So, I mean, the point is all of these systems need to be validated. So nobody can say that, I'm just going to create a model, on my laptop tonight and then roll it out into clinical practice tomorrow. That's not feasible. But so many of these systems are so powerful and more validated than any clinical tool in history because of the amount of data that they have access to for that validation. And as a result, I mean, they should be trusted more than your own intuition as a physician in many cases. So, if that's the case, it's almost unethical to not use it. If somebody comes into into an emergency room and you don't trust the latest technology, you don't trust your CT scan or whatever it is you might be using, people are going to suffer people are going to suffer from that, and that's because you're not keeping up with technology. The point is, a physician aided by these technologies will always outperform a physician who resists these technologies. And because you're dealing with patients' lives, if these are validated technologies, it's unethical to. I would go so far as to say it's unethical to not use them.
It sounds like the same as you need a human in the loop, right? There's still somebody who has to validate the outcomes based on their expertise. So that's, I imagine, also leading to a situation where you have newer physicians who are less experienced, that either they're going to adopt the technology and then rely on that, resist it, probably not resist it. So they're going to rely on the technology, but then you run into the issue, or I would guess that you're running into the issue of they're accepting the outputs at face value and maybe don't have the experience to step in and say, you know what, this is missing something. So now there's going to be a knowledge and experience gap where the more experienced you are as a physician, the better you can interpret the outputs. The less experienced, well, now you're really relying wholly on what the system is outputting.
Yeah, I think there's a lot of truth to that, and it also goes into how these systems actually make recommendations. So you look at, there are several commercially available diabetic retinopathy AI systems right now. Those systems aren't considered diagnostic; they're considered screening tools. So the way that they work is, the idea is to democratize access to a system that is able to reassure the vast majority of people. So, people with diabetes should have their eyes assessed at least once a year for diabetic retinopathy, instead of going to an ophthalmologist and having their pupils dilated and, all of the accessibility concerns that arise from that process. They could have photographs taken of the back of the eye, and that's a very automated process. That's something that can be rolled out very widely. And then these systems will look at the photographs and say not whether this person has diabetic retinopathy, but whether this person needs to see an ophthalmologist. So it's not necessarily diagnostic, but that's still hugely beneficial, and it really does still, it is still considered precision healthcare, because 3/4 of your patient cohort can automatically be reassured very safely to say, there's no evidence of diabetic retinopathy here. So you don't need to do anything further for another year. But in the quarter that remains, they're flagged for, all right, you actually need to see a human, and they go forward and get further assessment by a human specialist.
I would love to see a world where, and we're getting there, where we're better able to triage patients as they come in. And this is exactly what you're talking about is, you have a patient come in, let's assess them before they need to get to the specialist. So we can reduce the amount of referrals, we can reduce the amount of time that we're taking, both from PCP, but even those specialists, right? The specialist should be working on the really tough specialized cases, not just seeing everybody coming in and churning it out and then making the early determination of should you have even come here?
Yeah, I mean, the truth is, if care was truly accessible, the specialist wouldn't be able to deal with the numbers. So if we again just look at this one of many possible examples of diabetes, there are so many people with diabetes, there aren't enough specialists to do diabetic retinopathy screenings on all of them. You would overwhelm the entire profession if you tried to throw all of the people with diabetes at those clinicians. So there'd be nobody left to do eye surgeries, to deal with real complicated issues. So it's not it's really just supporting the entire system in a very productive way for everybody involved, whether that's the clinician or the patient or the payer. And just in terms of triaging, again, just going back to how much data we're throwing out there, and the idea of something like screening. Screening is by definition happening before a disease is diagnosed, often before noticeable symptoms, which are, symptoms arise. So you look at something like heart rate variability, that is a function of what controls that is your autonomic nervous system to a large extent. And that's a balance between your rest and digest, your parasympathetic nervous system, and your fight or flight, your sympathetic nervous system. And your parasympathetic nervous system is, a very strong contributor, therefore. So the reason I'm mentioning all of this is if you understand the physiology there's a vagus nerve, and that touches virtually every organ in your body and every system in the body. And chances are that all of these different diseases, whether it's diabetes, that has an impact on your autonomic nervous system, whether it's something going wrong in the stomach, the stomach is largely innervated by the vagus nerve, whether it's something going on in the pancreas, whether it's something going on, all of these different systems can feed back into the will have some fingerprint on the autonomic nervous system. And if you've got enough data, you can do so much in terms of, right now I'm just measuring your heart rate, but I'm not interested in your heart rate. I'm interested in the trend and how and those deviations that we were talking about. And I'm looking for fingerprints of illness. And the idea here is using these data and these sophisticated models, we can almost really be way more responsive. We can be way more proactive in terms of screening and getting people into the healthcare system earlier and at the right stage earlier, where it's still manageable. It can do a lot of good. It can save a lot of money. It can help treat patients, improve outcomes, improve survival rates, or it's just an extremely exciting and promising direction.
Most likely we could have a whole other talk. What you just touched on, as we're living longer, right? There's a couple different topics that begin to come up. One of them being aging in place. So how do we enable people to live out their lives at home and not having to keep going back or to stay in a clinical setting? But I think another one, what this is unlocking from what I'm getting from what you're saying, is aging well.
Yeah.
Right?
Absolutely.
What's the point of living to 120? There's some article saying that, hey, in a couple generations, we're going to be living to 200. What's the point if you're reliant on the healthcare system, if you are unable to function as a healthy adult? It just doesn't make any sense. Perhaps that's another topic we can touch on.
I mean, I'd love to.
Yeah. Any other final thoughts to wrap this up? This is really, really exciting stuff.
I mean, I think it's just the importance of combining a data-driven approach with a very clinical approach. So it's really just a message out there to anybody interested in the space or anybody building in the space. There are people who just focus on the clinical side, and then there are also people who just focus on the data side. And there are clinicians who say, we've always been data-driven, and that's true. But there's so much more opportunity if you really incorporate the latest cutting edge AI tools and data collection opportunities. And on the data analytics side, there's no shortage of people just completely ignoring the clinical aspects and the value of clinical insight in picking out these inputs and refining these models. So really, just anybody building in the space, try and get people in the team who understand both the clinical value and the data and the engineering value, because that's the real sweet spot, and that can be multiple people who just work really well together, or it can be individuals. There are plenty out there, but just don't ignore either side of those things.
And you're one of those people too. So
a little self promotion there.
Yeah,
but not exclusively for me.
Tell us, how do we get in contact with you? Where can you help to our listeners?
Yeah, I mean, I reach me on LinkedIn. I'm very responsive there, and you can also reach me. My website for my consulting business is innovahealth.ai, and yeah, either place is a good way to reach me out. I'm very excited to be working in the space. It makes me very happy every day. So yeah, bring me some difficult challenges, and that would make me very happy.
I love it. Thank you so much. Thank you to all of the folks that are listening in, both live as well as the recording afterwards, and looking forward to speaking with you again about future topics around better health outcomes. We didn't talk too much about social determinants of health, but that could be a whole other
100%.
aspect.
AJ, thank you so much. It's been great fun. So thank you for having me on.
Amazing. Thank you so much.
Take care.